Okay, welcome again to my kitchen classroom. Talking about hospital battlefield and everything you need to know and your family needs to know when you're hospitalized. Remember, we're talking about the standards of care and clinical instruction and communication theories and like that. So today we're going to talk about insurance, which is basically a very dull issue, I think, but it's vital because we all know that our lives are, and certainly in healthcare, are controlled by the insurance companies and the interactions between the hospitals and the insurance companies. It's the one part of this book I had the most trouble writing because I don't understand all of it, and Joe's my resource and my counsel to what actually the system is and how it goes. I have learned a lot about and what you need to know about insurance. Let's start with, have you read your policy? I haven't read my policy. You need to know what your insurance covers. That's crucial. I mean, maybe you don't have to. Our insurance is good. It's through the government. And every 3 months or 4 months they send you a handout with new updates on insurance and like that. So pretty much we're kept up to date by it. But the basic questions, what is your deductible? We all are familiar with deductibles, whether it's car insurance or health insurance or any insurance. There are deductibles. You need to know what yours is. You need to know what doctors it covers. They're called the network doctors. So is your doctor covered? What surgeons are covered? You have to know the network, what is covered. You need to know, for example, if you go to the emergency room, what is covered there. Because many times people have gotten to horrendous bills because you go there with your son and he has a cut on his face and they recommend you have a plastic surgeon take care of it because you don't want a scar. Logical, of course, you want the best, but lots of times the plastic surgeons are not in your network. So the bill you get from that hospitalization could be horrendous high. So you got to ask that question. Yes, I like a plastic surgeon to do this suturing, but is this plastic surgeon covered by my insurance? A logical question. And if they bring in any consultant, an endocrinologist, so they brought Joe in for an endocrine consult, would he be covered by your insurance? So that's a very important question that you need to ask. The other thing, let's talk about this in-house type things, honey. I think that's very important. You go to the emergency room. They don't want to discharge you right away. They want to watch you for 23 hours, Joe, is that what it is?
23 and a half hours, yes.
23 and a half hours. So they put you in a room, and a lot of people think they're admitted to the hospital, but you are not admitted to the hospital. So if you leave from that situation and try to go to physical therapy, they're not going to pay for it. So you have to, it's a strange thing, but you have to know. Well, you want to be there for observation because you don't want to go home if there's anything going on. The question is, will you be admitted? And if you're not admitted, what impact does it have if you're going to need physical therapy? You just got to sort it out. Your family can do that. You're in the emergency room, but your family can check that out for you to make sure that you have the insurance when you need it. I just saw something in the paper about that I thought was very interesting. This is about, therapists, costs leave patients in more pain. The question is, they are, when you go to some insurance, they are listed in the insurance as a specialist, okay? Specialists are paid more, and there's a point in which your insurance won't pay for specialists. And a lot of people have to stop physical therapy when they shouldn't because Medicare or the insurance company won't pay any longer. They're trying to change that in the system and make physical therapy the same as your general practitioner costs. But, you know, you need to know that when you start. You want to have physical therapy. It's very important, especially at a certain age, any age actually. But you have to figure out how long your insurance will pay for it. And maybe they'll change the law on that. I don't know. Did you know this, Joe?
Just now.
Just now, okay. But it changes all the time, you know. I wanted Joe to talk more. We'll do a little bit more about it. Being a medical director in a insurance company, but he said, well, he's been out of it for 15 years. But I still think there's basic principles about this aspect of it. Now, what else did I want to do? I wanted to do the insurance. There's certain terminologies.
You know, the hospital is a business, just remember
Oh,
that.
yeah. And healthcare is a business now.
They want to get you in and out,
Yeah.
and they want to get the most money they can for whatever ails you, but they want to do it in the shortest amount of time possible.
Yeah.
Now the other point is that very well what happens is they discharge you, and then you get readmitted. Now you get readmitted within that time span that they paid for the previous admission. And so what's going to happen is the insurance company is not going to pay for that second readmission. And the hospitals they try not to do that. They try to get some other diagnosis. But the point is that they want to make sure that you're not going to come back within that certain period of time. So it's kind of a game is what they play. But that's what business is.
It's a business, yeah. And you can't be discharged if you have a fever, right? Didn't you tell me that when you were in the hospital?
Well, you're not supposed to. You're not supposed to be discharged.
They have to find out what the fever is from. How about emergency rooms? They just send you out with a prescription for pain medication,
Well,
or
you may have a fever. That doesn't
necessarily mean you have to be
you gotta
admitted.
stay or be
But once
admitted.
you're admitted, don't you? They have to figure out where the cause of the fever is. I know with you,
They didn't find a cause.
I
of
know
the
they
fever.
did. Well, they finally said it was your lungs or something. Didn't they come up with something? They did. They didn't know. Remember anaplasmosis? They didn't know what he had. Remember we talked about that before. And they kept him 5 days. He was sick, really sick. But they finally did come up with a diagnosis of some residual lung fever. They did, honey. We could get your records and look at it. I remember that very well. But that's okay. It's just the idea that you're coded when and that's another thing. Let's talk about coding. When you're admitted to a hospital, you have a code. You have a number. It's all computerized.
Very specific
Very
diagnosis.
specific
right?
diagnosis.
The
And,
DRG.
and everything that is covered in Medicare or insurance is based on that coding. Now sometimes the doctor could put in the wrong code. That's possible. That's why if you're having
It's not
trouble
the doctor. They got coders that do that.
in their offices,
Yeah,
the doctor's not going to be bothered.
They're not
with
going to
that.
be bothered with
Well,
codes.
when I say the doctor, I mean his office
Yeah,
or his practice,
Or
whatever.
the
it is.
hospital itself.
And the hospital code.
The hospital's going to look for the best code so they get the
Okay.
most money.
Okay, that's your kind of wrinkling your nose, Courtney, at that.
That's crazy.
Well, you gotta understand, this is big business, and there's a lot of problems in it that, but it just, the more you know, the safer you are. In the hospital for treatments, but also afterwards in this insurance company thing. You need to know what you can do. I had a non-network MDs I talked about, observational units I talked about. We talked about hospitalists before, and the insurance company and the coding. Now, I have here in here doctor-to-doctor communication. Now, when you were medical director, remember I thought it was funny, a couple things. One doctor was,
Well, one was a very prominent surgeon in a very prestigious hospital. And I just needed to get some information. And obviously he was perturbed that he had to talk to someone. And his comment was, Sonny, why don't you get a real job?
So, you know,
And I kind of laughed and I said, I have a real job.
but it was that
But
kind
it was he was talking down and like, you know, why are you even bothering me? So
yeah,
that was very interesting.
yeah,
But most of the physicians, they were, you know, you talk to them on a one-to-one basis, they're pretty good.
yeah. You used to use a good counseling technique. You said, what did you say to them when you started?
Well, the way to kind of diffuse the antagonism is really to show that you really aren't challenging them. And what I used to say is, I don't understand, can I pick your brains? And let me tell you, when you say that to another physician, can I pick your brains, it just kind of opens up everything, the information. They kind of realize that you're not really challenging them, but you really just want just some information. Just tell me what's going on. Why is this, why is this patient in the hospital? Why is this patient in the hospital so long?
Yeah.
And that just opens up all kinds of things when you do that.
Yeah, I love that because the counselor in me, the soul in me says that's a wonderful approach to someone when you know that. And the basis of this book is not challenging people, caregivers, but asking to be a part of a dialogue, you know. So that's kind of core to me, and I love the way you do that. Joe came to that role with a lot of experience, board certified in internal medicine and endocrinology, but he wasn't a surgeon. And I got such a kick out of this because he always called, well, he did research on whatever the surgeon goes through, but he called all his buddies in the air. I'm sure, Joe, they got, oh my God, it's Joe Galanka again. What does he want now? But he would call his orthopedic friends and his surgeon friends. And he'd say, I read up on this new, what do you think about what's going on in this field? And I really gave him, because the clinical directors in hospitals come from a lot of different backgrounds. And they're hired by the insurance company, okay? So is there a quota you had to do, that you had to do so many rejections or anything?
No, they never said that. I'm sure that
They look
if
at
you
your
approved everything, you wouldn't be working for them
Yes.
for any length of time. They did have statistics on you for the year as far as how many denials, how many approvals, etc. And I know they had that, and they showed you what your statistics were. But that didn't bother me. I could care less about what my statistics were.
Well, but see, you had the strength of experience and knowledge and background. Wasn't one of the managers said to you something about and you said you didn't care because you were so good?
Oh yeah, well, one of
We don't name names, but
the VIPs came to inspect the system, and I'll never forget her. She said, she was from California. She said, "Why should I keep you?" And I said, "Because I'm good. That's why." And she just kind of left.
yeah, she
I
laughed
thought
and
that was
left.
very good.
Yeah.
But she did clear house though, and I know she did get rid of quite a few people. But I could care less.
Yeah, so you got to be in that. You have to have strength, clinical strength, and personal strength to work in the system and do the kind of review based on the facts.
Yeah.
And listen to the doctor.
And your experience too.
And your experience and your research, and it's very important. Now there was one other person that the one that cried. I kind of stayed in the background here, but I love this.
I was talking to this general practitioner, and he was an elderly. Well, not elderly, but he's been in practice for a while. And I'll never forget. He said to me, "I can't stand it anymore. I'm going to quit." And I said to him, "Don't quit. You're doing a good job."
Yeah. There's a certain, now medical students now, they have a course on insurance and insurance and what. I'm sure. I never checked the curriculum, but I bet anything, the interns and residents and medical students coming through, they know. But the doctors that were in it, and we do lose a lot of good doctors because they can't take this system of insurance and also the computerized.
Yeah, the electronic medical records, they don't like it at all.
They don't like it at all. Now, I was thinking about that. I was thinking about medical records. I think I told you earlier, when he was in the hospital, all the nurses had these little cubicles with their computer system, and they were typing away. And I have some questions about that. But I have a great primary care physician, and she comes in with the computer, and she looks at all the, well, it looks like you had some x-rays up in Saratoga or some things that. She uses it as a tool for for our discussion. It doesn't, it's there, but she types in, and I was a focus, and she used it as a tool, and I was very impressed by how she used it. I'm not always impressed by computers. And we talked for over half an hour. Excellent physical exam. It didn't get in the way, because computers can get in the way of dialogue and monitoring and like that, but it didn't. I was impressed by that. That was good. I told you that, right?
Yes, yeah.
She's an excellent doctor, so that's good. So you did the two things.
Remember, one other thing is, when I was talking to one doctor, and he wanted to know what I had to do to get the job, and were there any openings for him?
Yeah, he did ask the one. Was he actually crying, Joe? Or
No.
But he was really.
I just want to know how he could apply for a job, which I thought was funny.
How about Courtney? Do you have any questions? I mean, it's a very complex area, and but it's important. Now, the other thing is, when you're in the hospital, your job is to fight the illness. You're psychologically, physically, and you have your allies and everybody around you. When you're discharged, you're still fighting the illness or what you're doing. You don't need that burden of trying to work out with the insurance company. That's when you need to talk to people in your family. Now, you are the only one that can do the actual talking to the insurance company, because they're going to check out, who you are and all that. But you need to, Uncle Henry might be an insurance agent, or your Aunt Helen, I'm talking in our background, has particular knowledge because she worked in a field for a long time. Why not just call them in and say, look, I got a problem, they're not paying for this, and it's so confusing, and it's upsetting me a great deal, and I need to focus on getting well. Could you help me sort this out a little bit? So when I ask for a review, or the doctor asks for a review, I know what I'm doing, or it's just a simple thing, but I want you to fight the illness. I don't want you to be overwhelmed with all these questions or all these concepts. Now, I did take it. It's interesting. I was looking back at what I did in the book, because I had problems understanding all this insurance stuff. I put it in a mediation format, because I am a mediator too. So I thought, well, I'll use the format which is focusing on the issue, and a caucus, which is basically. So I have here a lot of questions that I asked Joe that he responded to. Let's see if there's any. I can hit you with a couple.
I probably don't remember what I said.
Well, you don't, but you'll. How about intensity of service? What does that mean when you're in an insurance format? Does it? Excuse me.
Well, what did I say?
It was good. It refers to acute care that requires hospital admission or continuation of hospitalization. Nationally recognized guidelines have been developed by outside sources which have determined standards of care. The Milliman Organization and Medicare have well-established guidelines.
Right.
Okay. So there's all sorts of data that you use. Okay, since you are not presently in clinical practice, how do you stay current in the clinical approaches and research?
I used to go to all the conferences, grand rounds, and just read journals.
Yeah, the New England Journal, you have that, you get that every week, still get that every week. Plus your telephone calls to your buddies, that was really good, I like that. Let's see. How does the medical director in an insurance company fit in with post-hospitalization appeals?
Well, the nurses, first of all, there's a certain time element that you have to, before if your appeal is going to be looked at, there's a time element, and if you're beyond that time element when they'll allow an appeal, they're not going to even look at it.
Well, then that's something the patient should know,
Yeah.
right? A family should know that if they're going to appeal, and they'll be in
It's in your
consultation
contract,
with their,
it'll tell you
yeah,
usually 30 days, but the point is, you better know what that time is.
and you'll be in contact with your physician's office,
Right.
and they're coding whatever they do, that would be very important. There's first level appeals and there's second level appeals, right?
Right.
If the first level is denied, you still have a right to go a second
With
level.
a peer, in other words, with a physician, that is their specialty. And a lot of times they'll outsource that
Oh, so the
appeal
second level would be,
to a specialist.
okay, so it would be a surgeon or a orthopedic surgeon or something, a second level appeal, okay. And the interesting thing is the data, there has to be written data, now be on computers now. What key points would lead you to support the original denial of coverage?
What do I say?
No new data that documents our unstable medical condition for continued inpatient. It's what you're saying basically. There has to be documentation about condition and many of the appeals are often surgeries that were considered cosmetic and not covered by the contract.
Yeah, but you got to remember now. It always has to do with beyond the coverage period.
Yeah.
And so the continued stay beyond whatever the
Most of them.
insurance company paid for. Saying, we're going to pay so much money for this.
Okay.
And if it's beyond that on a per diem basis, that's really what we're talking about.
Okay.
At least that's what we were talking about then.
So here, what should physicians do in denial of coverage cases? Well, before cases, you were always talking about what the doctor documents while the patient's in the hospital. Not general terms like patient is doing well. That's not helpful to you when there's a denial, right? Or clinically improved, well, that seems to indicate that there's nothing more that needs to be done in the hospital. It depends on the denial. I know that, I don't want to get into this too long because it kind of bores me too.
You got to
But,
remember though that the hospital's not going to get paid for the extended stay if there isn't a real good reason why.
Yeah.
And so they're going to want to discharge that patient as soon as possible.
Yeah.
Just remember that.
Yeah, that's interesting to me, that I guess in a kind of a final note, I'm going to tell you what we're going to do next, but I'd really like questions, but I think to summarize it, recognize it as a business, know what your coverage is, know what you need to do if coverage is denied with your physician. This is a cooperative venture because their office can do a lot to go after denials. And then know that the insurance company has to do certain things at certain stages, that they need physicians that are skilled in this, certainly the second level. I didn't know that, honey. That's interesting. I think that's interesting. And get yourself some allies in this fight. This is not something, you just get better. That's what you need to do. Courtney, questions at all that you have, or?
I do, but I feel like I should save them.
You want to
I
save
have
them?
many, yeah.
Okay, gotcha. That's what well, actually, here's the plan of action now. We did insurance today. Now, next week, Joe doesn't want me to do this, but I am a college professor. And you show me a college professor that doesn't have theories about why they're presenting something. So there are change theory, memory cognitive theories, redundancy is a kind of a concept, and my analogy. I'd like to talk about them a little bit. It's kind of a tying up thing. If you're not interested in it, you don't have to look at that YouTube, but that's it. And then we're going to finalize, maybe have some questions next week when I do theory. Then we can get into some questions. Which
I'm gonna go get a cup of coffee.
Who, you're going to get a couple?
Yeah, when you're giving that.
Well, you understand it. You've listened to me for all these years. I can't help it. I've spent 22 years in a college, so I got to do a little theoretical stuff. I just have to. And then we're going to do questions the next, start questions. We've been trying to get questions. We gave a talk this past week over at a senior center, actually in Saratoga. Wonderful group of people. We got some questions from there. Courtney's collecting some questions. There are some questions through the YouTube. Do we have any questions for
We'll have to look
our
again.
viewers?
We'll look again.
We'll look and see if there's some there. My bridge group, we're going to ask them for some questions. It's awfully important. That's what I miss in this, the YouTube. I can't kind of interact with you, the listener, and answer your questions. So we'll try to end up with as many questions as we can get. So that's the plan, and then it's, spread the word. I can only say that to your friends if you think this would be helpful to the family, friends. Okay, Joe, anything else?
No, that was very good.
Okay. Goodbye for now. See you